neovascular dilation, and you inject antiviral, for example, Avastin, in the uterus for reduce corneal neovascular dilation, and how can you use and how many time and how does the result, and also why do we don't choose other technique for reduce corneal neovascular dilation?
Thank you, Dr. Sun, for your question. About your question, these drugs can be used as one option to treat the corneal vascularization, but this treatment needs to be studied furthermore and is not approved by the ophthalmologist. And about the case report, the effect of this drug to the disease, there's only one case reported. The HFP epithelial appeared 3 days after the injection, and then we stop the injection and we cure the disease. It is gone. But this does not show that this drug have quite the relationship to the disease.
Just for the one case,
yeah,
where is used in America or which country?
In America.
Yeah, so they also not important as a result. So sometimes it's a long time, about more than 15 years ago, when some patients have a corneal neovascular dilation, I already use accommodation for treatment of corneal neovascular dilation. And when I follow my patient, and it's a very good result, and the patient, after I check the neovascular dilation, is a corneal gone. So any other question for audience? Any question or comment for Dr. Hill? Dr. Dong, you have a question or comment for Dr. Hill? Specialist in cornea.
Thank you, Dr. Hill. Thank you for your English also. It's quite clear to see that as a clinical picture of the hepatitis, keratitis, and also the way to treat the patient. But in reality, how can you treat our patient? For example, you will combine between the topical ointment and the oral acyclovir or not, or you use only topical and you don't use orals. What do you think?
For the real use, I use the combination of both drugs. As I think this is a empirical use based on our experience.
So to be sure that we can use, we can maximize the effectiveness of the anti-hepatic. Is that true? Yeah.
Yes, because the results show that we use two drugs, the epitheliums and all the disease may relieve faster, but this result have no statistical meaning.
Yeah. And there's some clinical picture, for example, for the epithelial keratitis and even endothelitis due to hepatitis. What should we should differentiate with other diseases? Should we do that? Because there's some clinical picture, it looks similar to the dendritic ulcer, but in fact it's not. So how can you differentiate?
To differentiate because the dendritic keratitis is quite typical with the each base of the branch on the corneas, and I will use the cornea and check the corneal sensation and the history of the patient to make sure that this disease is the HSP keratitis, because the disease is progress slowly. The patient would have the red eye first and then turn to the dendritic also.
In some cases, especially ancatomera, we can see the picture like that. It looks like dendritic. So for that case, we should pay attention on the symptom of the patient. Usually, due to acanthomegaly, the patient has very severe symptoms. but the sign is not quite similar. Thank you.
Okay, thank you very much. There's any other question or comment from audience? Dr. Keung, yes.
Thank you for your presentation. I highly appreciate your English skill and your well prepared presentation. I think. To the diagnostic differentiation that you think I want to maybe ask you to make the different diagnostic more with in scale endo the arterial lesion to well diagnostic with Postner-Solzman syndrome, locomotor athletics, glaucoma. You should do a diagnostic with that. And you have any document in literature, someone find out unfound beta interferon may be with SFB characteristic a lot. And by the way, Professor Sun here, I sent some case with a scar. I don't know after SFB characteristic or not. The scar, corneal scar, located well in the center of the cornea. And I sent you, I may ask you to do the LASIK to move that. And I hope that, but you answered me that we don't have a price list until now, and we could not collect money from the patient. So I think it's a very regretful case. So I think in the near future we should have a price list with LASIK or something like that to treat with the scar, corneal scar, located well in the center. There was a big layer above one or under one. I think it's not very, very thin scar. So thank you. Interferon.
Okay, yes.
Thank you
Question.
for your questions. The first question, to differentiate the AHB endothelials with the Postner-Solzman syndrome or the locomotor hydrocephalus, I think the sign quite clear because here in the endothelial keratitis, the stromal or the epithelial edema shaped in a round or oval. And also we have found the visit bed, but without any sign of the anterior uveitis. We do not find the cells or the flare in the anterior chambers. And in the endothelial keratitis, the patient also will have the white-free immune ring in the nostril haze, like it on the screen. About the interferon use, in this guideline, their study show that the interferon use together with the antiviral agent can hasten the healing of the disease, but because the drug is not approved by FDA, so there's no further study about this.
Okay, thank you much. Concerned about the question, Dr. Keung, does there some patient with corneal scarring? When and he asked how we can do the LASIK or PRK for treatment for the patient. Yes, he said it's a very right way. Some patient, if the patient have a scar in the cornea, we can use excimer laser for treatment. And there's two problems that we cannot carry on in a hospital. Mostly there is some patient. I ask the company, they support us. The machine, like now we have the swing machine, we can do non-contact like in the swing machine, they can do the non-contact and for the laser. But when I asked the company, and they said even now they have not update for the software for treatment for scarring in the patient. And I asked since a long time, about nearly 6 months ago, But until now, they cannot update for us for software for treatment for the patient with scarring in the cornea. And another way, and the patient can pay the money, and also we cannot have the price for the patient, yes. But after now, we can ask the company again for they have update the software for treatment of the patient. With some patients, the scarring cornea is very good for treatment. And there's other question or comment? Yes, Dr. Tan.
Where's the resident?
I want to have some comment about the post-nasal syndrome and also the differential diagnosis between anterior uveitis due to this virus and also post-nasal syndrome. So because he said that in endothelial keratitis, there's no signs of anterior segment or no signs of anterior uveitis, not true. Because those two clinical entities very similar, and sometimes it's very difficult to tell the difference because we also have problem with cornea with plastic text. They also have cells and flare. They also have problem with the iritis. So you have to keep in mind that there are two clinical entities that can have anterior uveitis with high IOP, that herpetics, keratitis, endothelial keratitis, and also anterior segment involvement, and also post-nasal syndrome. But I think there are two clinical signs very important to differentiate between the two. First thing is the characteristic of the precipitate. So in the post-nasal syndrome, normally the precipitate is round and focused on the center of the cornea, only center. But in the herpetic uveitis, it tends to be in the inferior part. They form the shape of triangle, with the proper name, that the arc triangle. So that one can help you to differentiate. The second sign is the iritis, because in the post-nasal syndrome, normally is no very well clear, patchy iritis. But in the herpetic uveitis, you can see that the patchy atrophy of the iris is very important. And sometimes you can also see the posterior synechium. But in the post-nasal syndrome, you never see those cases because of the inflammation in the interchangeable segment. It's not severe enough to cause the posterior synechium. And also, sometimes you can see the heterochromia, means that the fading color of the iris, but no patchy atrophy of the iris. So that, I think there are two signs that we know to differentiate. And another comment about the using of prostaglandin in the anterior segment uveitis. There is only one study, clinical study, that comparing between the two groups of patients, with one group with high IOP but treated with other agents, and one group with prostaglandin and specifically here in lanatopros. And the group treated with lanatopros, they saw the higher rate of recurrence after several months of the lanatopros problem. So, but I think it's just only one clinical study reported in literature. So that's why until now, the treatment of the high IOP anterior uveitis is still debatable, still questionable. Some suggested that maybe you can try even with post-nasal syndrome in the very late phase with quiet treatment, no more inflammation, but IOP is still high. You can try to treat with prostaglandin and see what's happening, because some cases can respond very well with the prostaglandin analog because of the, you know that there are two kind of receptor for prostaglandin. Prostaglandin is a chemical can increase the inflammatory reaction, but there are two kind of receptor, receptor alpha, receptor beta. But now the prostaglandin analog for IOP lowering is very specific to the alpha analog, so it can be used for selected cases with very close follow-up.
Okay, thank you very much, Dr. Tan. And there's any other question? No more? Dr. Yang.
Thank you very much, Dr. Hill, for the presentations. I highly appreciate the preparations in terms of preparing the slides as well as the English. But it's better if you speak or if you spoke slower in order everybody can follow the presentations. That's better. I just want to ask Dr. Hill and the young doctors who are working in the cornea department. Say the diagnosis of epipsynclic keratitis is difficult or easy? That's my question. To diagnose the epipsynclic keratitis, is it easy or difficult?
Well, until now, thank you for your question. Until now, I find it quite not difficult because maybe the HFV virus is the main cause of the viral disease in the cornea. It may be differentiate with the adenovirus in some cases.
Okay. How about the doctors in cornea department? Who have young doctor?
Only old Dr. Dong here.
Subject.
No worry.
Okay.
Chan.
Chan, Dr. Chan.
How many doctors in cornea department? This is the topics of the cornea department. And very few doctors attending.
Không phải vẫn ở đâu. Bố vào cái màng ấy.
Hello. For me, it's not easy in some special case, especially for the tumor keratitis HSP.
So it's easy or difficult?
It's not easy.
Difficult.
Sometimes it's difficult.
It's not easy, it means difficult. That's the only one option. One question, one answer. Is it easy or difficult? So how about Dr. Zul, young doctor?
For me, I think it's sometimes difficult to diagnose about SSP keratitis.
Otherwise, it's easy. There's only some special cases difficult.
I think difficult.
How about others? Who else? Dr. Han.
In my opinion, I think it depends on each case of patients that we see. Sometimes we can get the diagnosis of the tumor keratitis that with the ulcerations if it has some typical features on lesions on cornea, and based on the history of the patients. And sometimes we have to consider other diagnoses such as microsporidea.
No. What is the percentage of typical cases of herpes simplex keratitis?
For the precise number, I don't remember, and I think it's quite difficult to answer.
Dr. Sun, you get my questions. What
For me-
is the prevalence or percentage of the typical herpes simplex keratitis?
For the typical cases of SSP keratitis, I think it's 1/3. It's typical when SSP
Yes, okay. What clinical features to be considered as a typical?
Is the dendritic and geographic keratitis is everyone can see is a typical keratitis due to the HSP.
What else?
And maybe DC4. Yes.
Say, as Dr. Sam said, and I think just around, it's only 1/3 or less having typical clinical features. Say, 2/3 is very difficult. So, because it's very important to diagnose herpes simplex keratitis, because if you are miss or wrongly diagnosed, it results in, you see, say wrong treatment, and it may cause a very severe consequence for the patients. And if you see, even you diagnose rightly, sometimes the treatment also very difficult. And the doctor here's presentation still lacking something very important. That's why he said, oh, this is not easy, or this is not difficult to diagnose. If you go back to 2 clinical cases you presented, the first one, say why you diagnose this is the herpes simplex keratitis. What is the golden standards for diagnosis? So, Dr. Sam, say for example, this case with such size, why you diagnose this is the simplex, herpes simplex virus, the keratitis?
For this